In our study, so using the nccRCC database, we were able to demonstrate that survival outcomes are actually comparable after surgical resection for renal cell carcinoma with tumor thrombus extension, irrespective of histology. Now, previous studies had been done looking at non-clear cell RCC and survival outcomes after surgical resection. However, given the rarity of non-clear cell RCC with tumor thrombus extension and the heterogeneity of non-clear cell RCC, most of those studies were single institutional studies, and the reported outcomes had been inconsistent. Our study is the first to utilize a large, nationally representative cohort from the nccRCC database and show that survival outcomes are actually comparable. We were able to do that because nccR started capturing information on tumor thrombus extension and RCC back in 2010, and so we were able to use this contemporary cohort of patients to show our results. In our study, although we were able to, look at non-clear cell RCC as a bigger group and compare it to clear cell RCC, looking at specific histologic subtypes of non-clear cell RCC was not really possible, just given our numbers. We had a total of 380 patients with non-clear cell RCC, and that was compared as a group. However, I will say that we did look at the distribution of the different subtypes in our cohort, and interestingly, when we look at the entire cohort with any tumor thrombus extension, it was, chromophobe RCC was common, papillary non-clear cell RCC was also common. When we looked at a sub-analysis of our study and looked exclusively at patients with tumor thrombus extension up to the IVC and re-looked at the distribution of the histologic subtypes, we found that actually papillary RCC demonstrated the majority of those patients that had tumor thrombus extension up to the IVC. And so that could suggest that papillary RCC is a more aggressive subtype in the setting of tumor thrombus extension and is the one that drives most of tumor thrombus formation up into the inferior vena cava. But again, we didn't do any direct subtype analyses, just given the limited numbers. We will try to, again, as we continue to gather more data, hopefully with more numbers in the upcoming years, we would be able to do some histology-specific analyses. Systemic therapy is actually now commonly utilized in the setting of tumor thrombus extension, and particularly non-metastatic disease. Adjuvant pembrolizumab was approved actually for use in clear cell RCC back in 2021 and is now administered routinely in this setting. There are less studied and systemic therapies for non-clear cell RCC, which is what our study highlights essentially, is that after surgery, given the comparable survival outcomes and the lack of any well-studied adjuvant options in the non-clear cell RCC space, calls for further studies to look into that specifically, given the understudied disease nature here. Our findings did demonstrate comparable survival outcomes for patients with tumor thrombus arising from RCC, irrespective of histology, after surgical resection, and highlights that there is indeed an imperative role for surgery in this setting. Now, it's important to note that in the clinical world, we don't really biopsy all patients with a renal renal tumor and thrombus extending to the IVC, or tumor thrombus extension in general, and so we don't necessarily know the histology pre-op. However, again, what our findings suggest is that irrespective of what the histology is, in this setting, in a patient with a renal tumor and tumor thrombus extension, primary treatment remains surgical resection. And then what we want to look into essentially is again, the role of adjuvant systemic therapies postoperatively, especially in non-clear cell RCC. There are certain limitations again with the SEER data set that we used to do the study, particularly as all these national databases, we don't have granular data that as much as we would like. So the next steps would be to look at this in a large multi-institutional fashion, where we would be able to gather more data on prognostic variables that will be important to look into, and I think that will allow us to get better outcomes and better data insight into what's happening.